Good afternoon, everyone. I would like to welcome you all to our first Ask DOC Pain educational session. My name is Rebecca Nix, and I'm the Outreach Coordinator for DOC Pain. And I do want to thank you for taking time out of your busy day to join us. Our goal here today is just to provide a brief interactive forum with healthcare providers so they can ask questions, discuss common pain conditions, and learn more about today's pain management treatment options. We'll hope you'll leave with some practical information you can use in caring for your patients. So I'm pleased to introduce our medical director, Dr. Paresh Mehta, and our nurse practitioner, Jackie Papolius. And today they will be discussing lumbar stenosis along with practical considerations for evaluation and treatment. Dr. Mehta, I'll turn it over to you.
Great. Thanks, Rebecca. Thank you for organizing this, and Jackie, always thank you for joining on this amazing discussion. I really like to discuss this in detail with my patients, but then more importantly, the colleagues in our community about, what stenosis is and some options we have for our patients. So, Jackie, I wanted to kind of ask you just a quick question of, how often do you see these patients in our practice and what are you looking for when they come to your clinic setting?
Yeah. So we do see a lot of patients in clinic with spinal stenosis. Not all patients, interestingly enough, with spinal stenosis have symptoms of spinal stenosis. So really evaluating the patient, listening to what they have to say and really identifying things to determine, whether or not that spinal stenosis is what's driving their symptoms is super important. But on average, I see 2 new patients a day, 5 days a week, and I would say half of them have some component of back and leg pain. And to me, that's a patient coming in complaining of pain in their back, shooting down one or both legs, even some numbness, tingling, weakness and heaviness in their legs with standing and walking. That's the classic spinal stenosis patient.
Yeah, and I'm glad you brought that up, that not every patient with stenosis has symptoms. And so, I think our focus in our clinic is to really pair their symptoms with their imaging. And so, we see patients all day that might have imaging findings of severe stenosis, but their pain is purely neuropathy or diabetic neuropathy related. So I think, to your point, it's important to ask those questions about, do you have pain with walking? How far can you walk without getting that claudication down your legs? Just sitting, relieve your symptoms. Does flexion relieve your symptoms? So, I think it's, stenosis is unfortunately very common, but I think not everyone has symptoms related to it. So, I think that's what we try to do in our clinic is to identify who's really driving from that stenosis picture. In your mind, kind of on that point, where do you see symptoms from a mild, moderate, or severe stenotic picture? I mean, what are kind of, how do you weigh those grading scales into symptomology and kind of your potential treatment options, for that patient?
Yeah, I think it's looking at the patient as a whole. You might have a patient that has severe stenosis on an MRI that does have symptoms that support it, but may not be an ideal surgical candidate. So we treat those patients with minimally invasive options like, medications, PT, injections, and some other minimally invasive procedures. So, I think mild, moderate to severe, I think we look at those things, but we really treat the patient and their subjective symptoms when they come in.
Yeah, exactly. And so, I mean, I think, this is a condition we see most likely in our elderly population. Stenosis, I think, is an umbrella term, right? And so we do like to break it down as to what's driving that stenosis, whether it's a disc herniation narrowing the canal, is it the facets encroaching, or is it the ligament that's hypertrophied narrowing the canal? And so that really helps us dictate what treatment might be best for that patient, whether it's, starting off with physical therapy, really working on strengthening the core, the hips, maybe progressing that to isolating the disc and controlling that with an epidural injection, or even something like MIS procedure that can really reopen that canal to give that patient relief is kind of what we're looking for as far as strategies we can provide that patient.
Do
Do
you have like a
you,
certain, oh, go ahead.
oh, I'm sorry, I should raise
No,
my
go
hand.
ahead. Go ahead, Rebecca.
Do you guys ever use like weight management as an option for these patients? I mean,
Yeah,
is
that's
that something along with the physical therapy, medication management? I mean, does weight play a factor sometimes into the lumbar stenosis?
Yeah, absolutely. I think weight, the heavier the patient, the more weight there is on the disc, right? And that, like we said, is a contributor of stenosis. More wear and tear to the disc causes more stress to the joints and the posterior elements as well, which can lead to progressive stenosis. So I think, yes, therapy strengthens the core, but I think losing weight in conjunction with therapy can help that patient, lessen the likelihood of developing progressive stenosis. And so it certainly is a conversation. We haven't had many patients, endorse the GLP-1s and those types of things for weight loss, but it's certainly a conversation piece if we can help patients do that. Similar to like a total knee replacement, or knee arthritis. If the patient can lose some weight, that will help the general health of that knee long term. And so
How do
certainly
you,
things we progress.
how do you handle that with a patient? I mean, I know some people might be a bit sensitive with their weight. Is
Mhm.
that something that you find it being a difficult conversation with your patient?
Jackie, how do you, yeah,
Yeah, well,
you're better at this than I am.
it's actually interesting because I had this conversation with a patient earlier today. Morbidly obese male. He's now had several different types of injections to treat various different pain generators, and nothing seems to be helping. So you just have to have that conversation. I mean, you can say things tactfully, of course, but we talk about, strategies to lose weight. It's not just about, the medications or the injectables. It's, the nutrition aspect, the physical well-being. So, I offered him a bariatric referral. Do you want to meet with bariatrics? Do you want to, have the conversations about, evaluating diet and, also consider medications? There are, lots of medication options nowadays that I've also had some personal experience with. So I definitely think weight plays a huge role, not just physically, but mentally in the
Sure.
lives of our patients. So it's super important.
Yeah.
Yeah, yeah. And
Okay.
I think a lot of the strategies, I think if we talk about, therapy being an important aspect, and then now epidurals as a strategy to control inflammation and pain, I think it's setting the expectation. And so similar to when we talk about weight loss and physical therapies, expectation that, short-term gains, right? We want to make realistic improvements on how we're going to reduce our weight, how we're going to incorporate those diet changes. Similarly, I tell my patients the epidurals are really providing you short-term relief so that we can get you to function better, right? And so I think when you look at the literature, really the epidural efficacy when it comes to lumbar stenosis is anywhere from, 1 week to 6 months, right? And so I think it's understanding the expectations of what the epidurals are going to do. Patients come to our clinic with stenosis and they're like, you know what? This epidural is going to cure me. And I say, yes, it might
Mhm.
help, but pair that with a good physical therapy program, a weight loss program, you know, cognitive behavioral therapy, other modalities to really combat this from a multimodal level that results in overall better outcomes, right? And so, we want to obviously do epidurals to treat the pain, the inflammation, but it really is kind of this expectation of what it's going to do, which results in better outcomes overall.
I think that's an important thing to mention too, is that back pain is multifactorial. So even if we're treating your stenosis pain, you might still have facet pain, you might still have that arthritic pain. So, there are other options if this doesn't provide, enough relief, to treat different pain generators.
Yeah.
So
So,
setting those
Jackie,
expectations. Yeah.
when would you tell a provider, let's say a family practice provider, when would you say they should refer to pain management? What would be the tipping point for them to say, I can't manage your pain anymore. I need to send you out to a specialty.
Yeah. I think it's important. I think, any ailment warrants a good course of physical therapy. And I would say if things like physical therapy, anti-inflammatories, this pain is still lingering, I think at that point it's probably time to refer to pain to talk about some additional options.
Okay, great.
Yeah, and from that angle, where do you feel what medications, Jackie, would you try on that patient with stenosis? What medications would you maybe want to avoid in this
Yeah.
patient population, knowing that it's kind of an elderly population that typically gets this?
Yeah. I think that conversation is also individualized based on the patient and their comorbidities. Anti-inflammatories are good medications, especially for arthritic pain, joint pain in and of itself. But if you have a patient that has had, kidney disease or gastric ulcers, that's certainly a drug class you want to avoid. In the elderly, especially, we do use neuropathic agents to help manage those radicular symptoms. Gabapentin is one. I personally, if I'm starting a patient on gabapentin, I start very low, 100 3 times a day. I see them again in a month if they're doing okay, but not really noticing a substantial relief in symptoms. I will then bump them up to 3. Gabapentin can have some unwanted side effects initially, dizziness, being off balance, sedation, which is not something our elderly population or really anyone should have. So I tend to start low and go slow. If gabapentin is poorly tolerated, Lyrica is another great option. I think it tends to have less of those sedating side effects. So I think that's a good option sometimes for older adults.
How are you
Yeah,
managing, with all the, I get patients ask me all the time of, I saw gabapentin now causes dementia,
yeah,
early onset
yeah,
Alzheimer's. So,
yeah,
we know it can be effective, but then you
yeah,
also pair that with the challenge of what we're hearing in the community and
yeah,
the media about the
yeah,
negative effects of gabapentin. How are your patients perceiving that, and how's that been a challenge in the
yeah.
practice?
I've had a couple of patients come in after, they saw so and so on TikTok, doing a video about how awful gabapentin is. So, we navigate those challenges. I think I actually personally watched an influencer. Her name is Dr. Betsy Grunch. She's a neurosurgeon out
Yeah.
in Georgia, and she did a video on this. And really, where she said those studies were flawed in terms of gabapentin is that they really weren't looking at, the individual's lifestyle factors as well, which we know plays a huge role in developing cognitive deficits over time. So I just tell patients, it is a risk benefit conversation. It's like quality of life versus, potential long-term implications. We do have to look at those things. So I've had a couple patients really insistent that they want to taper off of that, which I'm happy to work with them on. But I would say the vast majority of patients do get relief from those medications, and you will find once you do start to taper, they notice that those symptoms are heightened and coming back. So most patients are okay to kind of stay on what they've been on for a while.
Yeah, yeah, and then kind of going back to Rebecca, your comment about when is it, important to refer, when would a primary care refer? I think,
Mhm.
ideally it's important to conceptualize that therapy can help. Therapy is a lifelong treatment, right? So,
Right.
initial stages is important, and then, I think to understand the limitations of medications, right? Medications can help, but they're not necessarily treating the stenosis, right? So, we know it's an inflammatory structural component that's causing the symptoms. So somebody that might be on gabapentin, say 300 3 times a day, they're still not getting the relief because, gabapentin is not treating the inflammation, not treating the structural problem. That might be a good opportunity to refer to interventional pain, before surgery because we can now implement the epidural strategies to help control inflammation, maybe some MIS strategies to really debulk that canal. So, I think when the primary care is often stuck of, hey, this medication is not working, what are other options? That's
Mhm.
typically the time we see a lot of those patients referred to the clinic and can have a really good conversation with them about what we're doing to structurally improve that stenosis, I think is valuable.
Yeah.
So do
One
you
more.
have a
Oh,
surgical procedure that actually like cures a person of the lumbar stenosis, or does it just really help their pain? Or what do you do surgically to correct the problem?
can
Yeah,
I
yeah,
jump in one more real quick just
Yeah.
about the medication piece and then we
Okay,
can
I'm
move on to
sorry.
the surgery? No, you're totally fine. I was just also going to mention we do use a lot of antidepressant type medications to help manage neuropathic pain, duloxetine, Cymbalta. And then we also use amitriptyline quite a bit at nighttime. You do have to be careful with those medications sometimes in the elderly populations due to their anticholinergic side effects. Again, just in terms of medication management, that's ones that are
Okay.
heavily utilized, but you do have to be careful with older adults.
Okay. That's
Okay, that's
great.
all.
That's good information. Thank you, Jackie.
Yeah, no problem. All right, you're on, Dr. Mehta.
yeah. So, I mean, I think transitioning to, what other strategies that we have, I think it's been very exciting in the pain management world over the last 5 years or so. Traditionally, we had, when it talks about stenosis, we had physical therapy, epidurals, and then surgery, either decompression, laminectomy, craniotomy, or, fusion as our pathway. Like I said, over the last 5 years, there's been a lot of interest into other options to give that patient after epidurals might have worn off or reduce their efficacy before major surgery options. And so basically it's called PILD or percutaneous image guided lumbar decompression. And really what we're trying to do here is with a small cannula debulk and remove some of the ligament that's narrowing that space. And so going back to what are the contributors of stenosis, one can be the facets overgrowing and narrowing that canal, the disc herniation, or that ligament that gets hypertrophied or gets thickened over time as we age. And so the idea with this piled procedure, PILD, is to go in with a very, very small incision under X-ray guidance and really debulk that ligament to open up that space. And so now what that's offered patients is a structural way to reduce that impedance, but then give them more room without the invasiveness of a surgery or a laminectomy or a fusion potential procedure. And so that's something that's been discussed in our practice quite a bit. We've been doing it for over 5 or 6 years in the community, and now a lot of the surgeons are looking at as options for their patients that might be higher cardiac risk or osteoporotic, can't have a bony fusion, can't undergo major anesthesia. Those are the indications that mild has a benefit because it can be done under local anesthesia or some light sedation in our practice. And so that's been a nice adjunct therapy to offer our patients in kind of that algorithm type care that we have.
That's great. So you find that being pretty successful as far as patient population?
It is. And I think it's, it goes to the conversation of what does that patient look like, right? And so, we see patients with I saw a patient the other day, multi-level stenosis, 68-year-old patient with basically moderate stenosis from L2 to L5, right? And so I think the conversation piece is not every level is symptomatic, right?
Right.
Where's your symptoms? Where is the symptomatic level? And so typically we'll do an epidural at that level, gauge their response, and if they get symptomatic improvement, we'll do the surgery at that level alone, right? We don't worry about the levels that are not symptomatic and causing their pain. And so now that patient might go to a surgeon and they might have to get multi-level fusion, right? In that scenario where when it comes to the piled procedure, we can really target our approach, hone in on the structural elements that are causing impingement and just really debulk those in less than 10 minutes. And so it's really been a nice strategy for our patients with improved outcomes, right? And so improved outcomes paired with physical therapy, paired with medications, paired with all those other modalities that we know tried and true can really give some of that improvement to that patient.
What's the recovery time for something like that?
Yeah, so because we're not debulking the bone and reducing that stress, the patient really has no major precautions.
Okay.
They go home with a Band-Aid on their back, no stitches. They're able to ambulate and exercise from day one. There's no bracing involved, and so typically it's a nice way to allow that patient to continue back to what they needed to do. Whether it's work or life in general, they're really back to their baseline from the next day. So, again, a nice strategy to offer our patients. Not everyone is a candidate, but again, that's the discussion that we can have with that patient of the pros and cons of that.
So
Do
who
you
wouldn't,
find, oh,
I'm sorry,
no,
who would not be a candidate for a procedure like that?
Um, mostly patients that have had a previous fusion, right? If they've had previous surgery, then they might not be an ideal candidate for that procedure. So they might be candidates for other strategies. Jackie, what are your thoughts on kind of other options, after mild has failed or mild, is not an option for someone that had previous surgery?
yeah, I think it just depends on the nature of their complaints. We do a lot of nerve blocks and ablations for patients that have had previous fusions and have a lot of axial symptoms. So I think that could be an option. But also, this is a great option to talk about spinal cord stimulation. We do a lot of neuromodulation in our clinic for patients that have had previous back surgeries and still have persistent symptoms, which involves implanting a battery underneath the skin, having some leads that come up off of those sutured into the spinal space, and really try to block some of those painful signals and kind of replaces some of those painful ones with some more tolerable sensations. So, certainly an option for patients that aren't really a candidate for any more surgery, but have had surgery and have persistent symptoms.
Yeah, exactly.
Okay,
That's
that's
a great
great.
point.
Yeah.
How would a primary care or I guess any other specialty know the difference between lumbar stenosis and maybe like a herniated disc or something? Is there just a way to tell the difference? Would it be an MRI based or, other testing, or is there just kind of like a basic diagnosis where the provider might be able to tell the difference?
Great question, Jackie. I'll let you take this one.
Well, most time a lumbar disc herniation can contribute to that spinal stenosis. So that's a piece of it. And normally, if they're symptomatic from a lumbar disc herniation, they're having those radicular symptoms. So that pain that shoots down into the leg. Again, it could affect one or both legs. So that's kind of what we see. And then, as mentioned earlier, we do try to pair that with the imaging to see if their symptoms kind of correlate with what's going on at that level.
Yeah.
Does that
Yeah.
answer?
Okay.
Yeah.
Yeah.
Yeah, and typically just to add on that, disc herniation typically sitting or valsalva makes it worse because of that pressure on that disc versus the classic stenosis sitting, or leaning forward that helps the symptom. So that can differentiate
Oh,
a little bit whether it's a pure disc that's causing the pain or stenosis as driving that picture. So, again, it can be very tricky, right? Not every patient has one symptom. They could have a combination. And so, again, it becomes fun in our practice in our clinic to really tease that out and identify, hey, what's the pain generator today? How do we treat this pain, moving forward, in a systematic approach in the most conservative way that we can. So, but yeah, that's what we do. That's what we like doing. And so, those are great patients for our practice.
Yeah.
So.
that's wonderful. Well, we hope that, this was a very informative, Ask DOC Pain. We're going to continue these forums. So I believe we're going to do this quarterly. Um, I think that today was a great example of, please bring us questions, answers. Please reach out to me directly. I obviously sent invitations through LinkedIn. Please share this with other providers in your practice, anyone that you think that might benefit. Do you have any last, few comments, Dr. Mehta, as far as how you kind of want to wrap up this session, our very first one?
Yeah, no, I think this is again, a resource for the community. We can talk about stenosis for 2, 3 hours, but hopefully this provided some bullet points, overviews that you can kind of think of when you're talking to your patients, and then more importantly, give them options, in the community, from an interventional pain side that we can offer. But yeah, we look forward to kind of the next discussion and next webinar that we'll have. And like Rebecca said, feel free to drop any questions to her, and we can kind of get those answered.
Yeah, so just so everyone knows, my email is rnix@daytondoc.com. So I will email me directly. I'll make sure the appropriate provider, Dr. Mehta, Jackie, whoever can answer that question, and I will make sure we directly get back in touch with you. So we really appreciate everyone joining us today, and I believe we're going to schedule another one in October. So be on the lookout for a new post, but thank you so much, and everyone have a wonderful rest of your Tuesday.